Good morning. Thanks, Dave. This is a bright and early morning for us Californians, and the weather is not quite as agreeable as back home, but I'll weather through it with you. I'm really privileged to be here with you today and feel that we have a lot to share from California. In fact, that's what I've done in my presentation. As we in the Planning Committee set out to design this meeting today, we came up with hundreds of questions and ideas, and in fact gave a sheet and a half full of them to the people that are presenting today in terms of questions that should be answered and how things should be addressed. And so that's really what I'm going to do in my presentation, is follow that advice and try to answer some of these questions with our California template over it, because as you all know, California is where the future happens first, and that's where we are implementing the Affordable Care Act with guns blazing. We have the California Endowment, in fact, which is my employer, is really a leader in terms of the implementation, investing millions and millions of dollars to support the state in its implementation, and so we have quite a bit to share about that. I would like to go first to my PowerPoint, if that's possible, or if you have the videos fired up, I'll do either, but are we ready to go? I can't really think of anything without having a PowerPoint in front of me. So the health in the time of reform is what I thought of in terms of a theme here. It's kind of like love in the time of cholera, and I think the metaphor is intended. We are really at an auspicious time with our history in this privilege of being able to think about health reform and giving us some new opportunities. And as the President had said, that without a radical shift toward prevention and public health, we won't be successful in containing costs or improving the health of the American people. And I think that really says a lot about what we're talking about here in terms of population health. As Dave had alluded, there's no precise definition yet of population health. But if we think of it perhaps in these terms that are a little bit dichotomous, where rather than just focusing on an individual patient, we're focusing on the population as a whole, as our patient, the community, and all of the other total environmental community contexts that go along with that health status at a community level, at a population level. So this nexus between health care and population health might be described, as the Institute of Medicine did in a prior report, that the health strategies, interventions, and policies applied at the population level can advance current approaches to our nation's most pressing health concerns more efficiently and effectively than can isolated individual intensive actions within the clinical care sector. We're making some value judgments here, and I think that people from the health sector that are in this, the healthcare sector that are in this room, might think differently. But in terms of epidemiologic analysis and looking overall at the population's health, looking at models in other countries, we believe that there's good evidence for that statement. Activities that the IOM has undertaken prior to this one that have created recommendations, suggestions, analyses that point to the importance of population health that could be drawn into the context of the Affordable Care Act and the time that we're in now are numerous. I've just listed a few of them here. These are various studies, reports, committees, some of which are ongoing, some of which are completed. But as I look back over the list, we can build on this advice. In fact, we always should stand on the shoulders of those that have come before us, and I think that is really what this roundtable intends to do, is take that good advice and those findings, interpretations, and use them so that we could build new intelligence and new perspectives because of this great opportunity within the Affordable Care Act to cast population health now in a new light and take the recommendations forward into our reformed health system paradigm. So with the Affordable Care Act, we have unprecedented resources to prevent illness and keep people healthy. You're all familiar with the expansion of health insurance coverage and prevention services that are being supported at the clinical side and some in the community side too. Innovative models that are being appealed for, invited. There are provisions for health equity and a lot more provisions for health equity and disparities attention than I had recognized. But it is throughout the conditions, the standards, models that are intended to come through this act. Various incentives for building up the health workforce, especially at the primary care end, where the capacity is particularly in trouble because of the maldistribution. And then in terms of building up health homes, places where people can get contiguous, comprehensive, integrated care, potentially from teams, and have it transcend from the clinical realm into the community realm. Community benefits, accountability, this is the obligation that some not-for-profit hospitals have to provide for services and benefits to the community at large that they serve that go beyond just hospital care, and community transformation grants that we'll have more discussion about from other presenters in this meeting, and then, of course, a national prevention strategy that kind of sets the guidelines for us. I think the adage that we have to remember about this act, though, in terms of what we have before us, is that this opportunity gives us a pause for reflecting on the fact that it was years to get here, it's going to be years to get to the results, and it's probably going to be generations until we see this kind of transcendent public policy passed that we might be able to take advantage of. I know there are many who feel that it didn't go far enough, and there are those that have felt and still feel that it's gone too far. But the opportunity that we have is today, so we're seizing the moment and using this opportunity to build on it. The health dividend that has been spoken about in the prior IOM reports speaks to this whole issue of the Affordable Care Act and population health, because it reminds us that despite our wealth, we're really unhealthier across the board than our peers, and that's a population health evaluation or assessment. There's evidence that flattening the social gradient improves the health of all. That means that all of the different strata of society have differentiation in terms of their health status, and that flattening that, meaning making things more equitable so that people have opportunities to be as healthy as one another, and therefore produce more in terms of academic output and work output, labor output, produce more and provide more for society, really improves the health of all and the well-being of all. Transferring medical care, overspend, because we're going to hear over and over again that the medical care system needs to be made more efficient. I think you're seeing a lot of that debate here in Washington, and we're hearing it across the country too, how to become more efficient and not creep more and more towards 1 out of every 5 dollars in our economy in terms of how much is spent on the healthcare system, but try to stem that tide, but transferring that overspend back towards social and infrastructure investment so that we will be able to stabilize our economy and create better health and well-being of all. And again, that's a population health construct. And then focusing upstream interventions like policy and population health interventions offers some promise in moving us in the direction that we would want to see to have people become healthier. I think many of you are familiar with this diagram that shows in terms of the factors that influence health, behaviors and environment together, 70% of attribution, and medical care only 10% contribute to health status itself, whereas in terms of our spending, 3% or less go for prevention or population health kinds of activities, and 97% toward health care services. So there's really tremendous disparity or in terms of how we invest our dollars compared to where health really comes from, if we're talking about health and not health care simply as an insurance or as a disease curative event. In terms of wasted health spending, again, we have a lot of different categories this spending is going towards, and a lot of opportunities there we see to either recover lost revenue and perhaps redirect that toward more productive aims. But this is really where the ACA is focusing a lot of its attention in terms of reforming the payment system, reforming the clinical care systems so that improved quality occurs. And I've lost my ability to, oh, there we go. So we're in review recognizing that health happens here. This is the campaign that the California Endowment is waging across California to help people recognize that health largely depends on conditions where we live, learn, work, and play, and not just on the medical treatment that we receive. This is a reminder that health is not just in pills and in surgeries and in hospitals. We have to think more broadly than that, and it provides, I think, a very effective frame for expressing what is population health. And we refer to a social ecological model that our Office of Health Equity and the State Department of Public Health in California uses, and a lot of you have seen in research and studies, that talks about the social, community, family, and individual dimensions of where health has its bearings and has its beginnings, the social determinants of health, so to speak, and all of these different sufficiencies in our society that contribute to health and well-being, not just a doctor's visit or a surgery, but the economic stability and clean air, soil and water, ease of travel and communications, safe walkable neighborhoods, safe and secure shelters, and a resilient population. So all of those things matter. That's what we're building towards. And in various dimensions, the Affordable Care Act is giving us some opportunity to deal with each of those domains, some more fully than others, but we're then looking at the different strategies that can help us get there. Those factors that affect health have been illustrated by the Centers for Disease Control and Prevention in this pyramid, where we see that the socioeconomic factors, some of which I just recited to you, are at the bottom of the pyramid and have the greatest impact if we're able to affect those and change those, usually going to be through policy means and policy measures, but poverty, education, housing, inequality, and then moving up the pyramid, we see other interventions, protective interventions such as immunizations, clinical interventions such as high blood pressure control, and counseling and education having lesser and lesser impacts, but still being important to improve the health of the population, the total population at large, not just focused on single individuals. A lot of us across the country are talking about innovations with this Affordable Care Act. It's giving us the opportunity to perhaps think differently, maybe even disruptively, about how our health system is running. And a lot of that discussion is focused really on clinical innovation, on what is happening within the clinical care sector with regard to policy and pay for performance and transparency and insurance exchanges. In fact, I'm thinking that might be a reason why this auditorium isn't packed and overflowing is perhaps we have overload in Washington on the Affordable Care Act. I know that in terms of the news, daily news about the Affordable Care Act in California, front page news almost every day in almost every major newspaper in our state, some aspect of Affordable Care Act implementation. It is huge news, and people are hearing a lot about it and talking about it. And perhaps that's one great benefit. It's brought health to the front of people's minds. So that that we need to think in terms of changing this conversation, because indeed, while health is on the front of people's mind, it's health in a different way than population health in most regards, if you follow my drift. In the past, and perhaps even in the present, the attention has largely been to high-volume, high-cost personal services. That's where the dollars flow, that's where the attention flows, it's where the media gravitates. Compelling stories about individuals needing lung transplants or needing certain levels of care, research for gene therapies and very, very sophisticated medicine and helicopters flying to rescue people and intensive care and care at the end of life. All of these very, very important to society, and certainly I'll be in line for that when the time comes. But that isn't where population health receives its greatest support and power. In fact, where we need to be focusing attention to a much greater degree is around healthy lifestyles and healthy places, because that, in fact, will reduce the morbidity. It will compress it so that we have longer, healthier lives and a compressed term of morbidity where we actually need this high intensive care. And so our future, if it's to look bright, would have a redistribution of resource, redistribution of public attention, and changing social norms so that it becomes our priority to think and do healthy lifestyles and think and do healthy places so that we can have a healthier population and reduce our need for those high-cost services. In some circles, people are even thinking so forward, so ahead of the game here, that anticipating the end of fee-for-service. I know that's heresy in some corners of this country, and in fact, coming from California, I'm able to bring that message, but in fact, there's projections, and I think Steve Shortell's work, the Berkeley Forum that you're going to be hearing about midday, has anticipated some lifetime projection for the diminishing of fee-for-service and the onset of global payment in terms of reforming payment models for health care, but also optimizing lifelong health. It means perhaps empowering consumers and empowering the consumer side, the population side, to not only become healthier, learn how to become healthier and actually do things that help them to become healthier, but to advocate for that and to sustain it and to become true stewards for health in their families, in their neighborhoods, in their communities, and in their support for public policies. So some, like Neil Halfand, have been thinking about this a lot, and have even put it into a context of different system designs. He's calling our current system acute system 1.0 that focuses on episodic and non-integrated care, and a coordinated seamless healthcare system that focuses on accountable outcomes. But what we're trying to proceed to, advance to, in terms of advancement in advancing ways that everyone would benefit, both individual care as well as population health, would be through this community integrated health care where there's population-based reimbursement and community health is integrated, and that we're taking advantage of all the new technologies that are available for communications, for patient supports, for provider supports, and have truly a healthy population-centered system. In our campaign for increasing awareness about how important health is in Obamacare, we're talking about it even closing the health gap, because it does help us speak to equity and speak to inequities and provide tools in various programs so that we can close this gap, because we see it every day in California between communities that sometimes are even situated next to each other, such as in the flatlands and the hills of Oakland, where there's a 10-year lifespan difference, just if we look at the demographics. And that is not something that we should be tolerating in our society. But again, our framework for health equity allows us to look upstream at the determinants of health and discriminatory beliefs, misplacement of power, or at least disproportions of power, and social inequities that we need to deal with on the socio-ecological side of this diagram, and be able to feed then healthier people into the medical models where there is access and genetics and treatment systems and others that then deal with the products of our social ecological support systems. And right now we're failing in feeding into that system people that are broken, people that have worse health outcomes to begin with, and worse social outcomes. And we're really expecting the medical care delivery system to repair people that are not broken from medical means, but from social and environmental means. And it doesn't happen that way. It's not about Humpty Dumpty and being put back together again. So opportunities to improve population health through ACA implementation look like integrated population health into the healthcare system, elevating the priority for primary prevention and health equity and empowering consumers and improving quality and access via language and cultural competence. And some others are like bridging clinical care and community health in health homes and strengthening the safety net to serve the remaining uncovered, and increasing capacity to fix the maldistribution of the workforce, incentivizing workplace wellness. All of these you'll probably hear in some form or another spoken to by the models and innovations that we're going to hear in detail later today. Even replicating community transformation grants and community benefits through population health programs. But we also recognize that there are challenges, because healthcare is better understood and valued by the public than population health itself. The attention is focused in this other realm, and so it's going to take some effort to gain people's attention and really redirect the conversation to improving population health when there's so much attention being given to care. Healthcare and population health are unequal partners in resources and political clout, and their aims aren't aligned, and government and public health already doesn't sufficiently provide for the population's health, and the implementation really could shift some traditional public health and population health services into the delivery system, and I think some of our speakers will tell you how that's happening. I'll tell you how it's happening in California. Right now, we're rapidly implementing the health exchange and policies to get that to happen. We're committing to language and cultural competency standards, a massive outreach campaign to get people enrolled by 2014, and we're pushing for coverage for the remaining uninsured, even through immigration reform. How successful we're going to be is part of the question. The other part of the question is making sure that population health is preserved for that population. We're expanding Medi-Cal. In fact, that's some of the trade-off in terms of where resources would go, and indicators for population health are being agreed upon. Community centers of care, the FQHCs and other community clinics are being built up so that they can take on a capacity as being a health home that reaches into communities. And promotoras and community connectors are also being trained and retrained so that they can serve both the clinical spectrum, the clinical systems, as well as community health or population health services, and expanding the health workforce in underserved areas. But it's not all without trouble and difficulty. Just this week, we've had a tremendous fight in California over the budget, and the governor wanting to hold the line, Governor Brown, on the budget spending and wanting to take back money from the counties that have been responsible for indigent care, getting state monies to do so. But he's saying because of the Affordable Care Act, now you won't need to spend as much money on indigent care. We want that money back. It became really quite a struggle because we know that prevention doesn't happen overnight and it doesn't accrue savings overnight, yet he wanted that money back overnight, basically, in terms of the budget. The trade-off being wanting to spend the money on the expansion of Medi-Cal, additional bringing back service for dental care and other social services for needy populations, and they become difficult trade-offs, just like last year's Doc Fix, saying we needed to solve the problem with physician payment so that they would take Medicaid by taking money away from the Prevention Public Health Fund. These trade-offs are put in the public's eye, policymakers' notions, and feeling that the short-term savings or the short-term benefit of getting the health care delivery system issues solved and paid for is trumps any kind of prevention whose really payoff might not come for years yet to come, and that's a very short view of things. Things have turned out better as a result of negotiation, but public health was severely threatened by this recent budget tussle, and population health truly was in the public's eye being weighed against clinical care, and that's a very difficult fight. So our tensions really look like ACA implementation sucks all the air out of the room, and sorry for being indelicate, but as a matter of fact, all of this public and media attention and all of the discussions in the circles, if you get a group of health people together, the migration of the discussion goes to health care and enrollment and payment and floating the system, and people have very little time or tolerance for talking about things that have to do with prevention and population health and social aims. Their spirit, and in fact, in many cases, even their judgment tells them that they need to go there, but it becomes a second shift short end of the stick kind of thing. We've had a very, very active group in California called Let's Get Healthy California, and then the state implementation model coming together to try to put together a coherent plan for implementing state health reform with some innovative models. And we thought population health was going to be the real aim there, because the intention was to improve the health of Californians by 2020. But in fact, the room being weighed perhaps more heavily in favor of the healthcare people, but plenty of public health people there, still the conversation came around to a lot of the clinical system kinds of approaches and interventions that are going to get more attention than the population health interventions. But we're there to continue to hold up the banner and make sure that population health is attended to. But change truly is resisted, even in a peer-peer context, and especially if money is at risk. The bar that they hold for prevention is incredibly high, because you approach a health system and say, well, we can buy this many MRI machines or expand an emergency room to have more beds, and almost immediately you get support and money. But if you ask for a program to train 200 promotores, or expand some community programs that would help to get complete streets or parks or better crossings for kids in front of schools, you get a lot of resistance. Well, what kind of benefit is that going to be? And how do we know it's in the right spot? And whose neighborhood is it going to be in? Is it going to be in mine? And will we get a return on that investment? And it becomes a very difficult struggle. So. And if you're talking about this overspend and where the savings from that overspend might go, because we anticipate savings, isn't that part of the purpose of the Affordable Care Act, better care at a lower cost, greater value? Well, the return on the investment in a lot of the providers' minds goes back to the provider that created that savings, so to speak, or to the health plan and the health system itself. And very little thought is being given to plowing savings into prevention, which is really the argument that we're waging and we're trying to win, to say, well, let's start addressing the demand side. Aren't we all about the supply side here in this room? And don't we need to start talking about demand and what we do about that? So the limited resources issue is one where we come head to head with the differentiation in some of our camps, and people tend to recede back into their own camps. And so let's not be naive in this room about how important it is for us to figure out a way to build those bridges, to create the partnerships, create the level of understanding, and build a damn good business case for prevention, for public health, and for population health, because we're going to need it when we go to bat. And then dealing with that battle is going to be a lot more feasible. So we think in terms of community being the cure. I think when you think about population health, where the power comes from is from the voters, is from the people themselves who know what conditions exist and what their priorities are, and who know whether they're going to be able to follow or want to follow the kinds of good advice about eating healthier and exercising more that we all want to deliver. But it also tells us that we all have a role and we all stand to gain. So it's a collective idea that population health within the context of the Affordable Care Act is a win-win-win. The benefits not only accrue in terms of preventing preventable conditions and perhaps in the long run lowering costs, in the short run maybe reducing some of the acuity around asthma or diabetes care, some of the other things that you're going to hear about today. But it's also a number of co-benefits in terms of what people have to contribute, again, in terms of their productivity and their academic performance, in terms of their being able to continue to provide leadership within families and neighborhoods. So community empowerment and giving community the capacity to work on behalf of population health should be among our highest priorities, and it is in California. Because what we do is collaborate for health inequity. We think in terms of the individual medical care system and the public health system, but we also have community health around capacity, advocacy, partnership, stewardship, youth involvement. All of these things are extremely forward-thinking for us because we know we need to build and go there. Our Community Transformation Grant is one model for that, where we're implementing that kind of a model into the different ACA-funded chronic disease prevention programs that are now in most of the counties across the state, and in fact even the counties that are shaded in white there are being funded independently by the California Endowment and building on other programs that they have in those places to look like community transformation grant communities as well, because we know it's a great idea and it's a great model to put forward where community people working hand in glove with public health people are doing population health to maximize health through prevention, advancing health equity, and expanding the evidence base for policy and environmental and infrastructural changes. And they're using these strategic directions around the major health problems that affect large parts of the population, such as smoking and unhealthy eating and inactivity, and creating safer environments. Larry Brilliant said it very well, I think, at the Harvard School of Public Health commencement just a couple of weeks ago, that somehow the two sides of our national health debate, one outward looking at social justice and inclusion and one looking inward at high-quality patient care that's exclusionary, met then, and he means back in the 60s when Medicare and Medicaid came about, and even during the eradication of smallpox that he was involved in. But we must meet again now on sacred ground, sharing the profound obligation and great joy of improving the health of the people. This is what brings us together, healthcare sector, population health people, and that's what we must go forward with and march with that adage. I wanted to just show you a video or two, if we could, that tells us about this campaign in California.
With no insurance, you don't know what to do. You know, go to emergency and it's very expensive.
The biggest killer in America and England is diet-related disease. Whether it's cancers, diabetes, heart disease, they're all diet-related in a massive, massive way.
Health happens with prevention.
What's very important about the Affordable Care Act is that it shifts the focus from expensive care once people have a disease to preventing that disease from developing in the first place.
So many of these diseases that are connected to diet and to exercise are called preventable illnesses for a reason. You don't have to get them.
Time for small businesses has finally arrived.
Us having a small business, it's important for us to know that now, moving forward, we can be able to take advantage of those tax credits, to have health insurance for our employees.
It allows more access, greater ability for families to access services like preventative care, checkups, visits, immunization.
Parte de la prevención es proporcionarles los cuidados de salud que tengan, el cuidado de salud que necesitan, porque sin el cuidado de salud realmente no pueden crecer.
So this type of events is going to make sure that people, one, know how to eat healthy, two, they know that there's local clinics for local checkups.
¿Era elegible para diferentes programas?
Sí, califiqué para ahorita para el programa de bajo recurso.
Hay mucho que podemos hacer, pero tenemos que ponernos activos, porque la salud nos afecta a todos, ¿no? Si no la cuidamos, todos vamos a sufrir. Sí se puede.
Get educated, get engaged, get enrolled.
Let's work together to improve our communities. We have the power to make health happen.
La salud empieza con la prevención. Regístrese hoy.
Health happens here.
Health happens here.
La salud empieza aquí.
We find hypodermic needles, we find gun shell casings.
The
water here. It's contaminated by a naturally occurring arsenic.
So you don't see fresh fruit growing, you don't see gardens.
It's got to be welcoming and safe for kids and families. Making the park like a hub of services, so there's existing city services that can be brought in.
Arsenic in the body can create cancer in the skin, cancer in the liver. We invested $26,000 and we are delivering reliable, high-quality drinking water.
Someone who is sitting there with their family who maybe was struggling to bring fresh food or any type of food to the table can now walk into their backyard, go into a box, and have dinner ready in the minutes.
It's the community that's going to stop this pollution. It's the community that's going to stop the gangbangers.
My personal problem is also my neighbor's problem. It's my comadre's problem. It's everybody's problem, and what are we going to do about it?
Bringing collaboratives, bringing innovative solutions, bringing other ways to engage the community as a part of the solution is the best formula to address community concerns.
Well, there you have it. Proud to bring that to you. I'd like to invite Sane up because we'll have if you have questions, you can certainly ask them after the panel, but we're allowing some question-answer time after that. And right now we have a real treat for you with our first panel, and Sane will be the moderator for that. Thank you.